Well, ladies and gentlemen, we're here. We've got 150 registered for the show tonight, so we're a bit excited. We've got Dr. Gerard Ingham with us, and the session tonight is using random case analysis as a supervision tool. And as one of the researchers and generators of this particular topic, we've got a pretty good mind in the room to show us all how. So thanks very much for joining us. Uh, you're not going to hear too much from me tonight. Obviously, you'll want to hear from the resident expert. So just really quickly, we'd like to acknowledge the traditional lands and owners on which this meeting is taking place around the country, with all of you joining in eagerly. So thank you all for being here, and we do pay our respects to the traditional owners, their elders past, present, and their families. Now, really quickly, just some really basic housekeeping. Obviously, with 150 people registered, it gets a little bit unruly to try and manage everybody wanting to ask a question. We do want you to ask questions, however, and so we do have the chat box. I'll put a little indicator there. You should be able to see something flashing orange and yellow there now. That's where you can actually put down, I'll type something. Hello. That's where you can ask your questions throughout the session, and anything that is asked that has not yet been answered, we will colour in red, and anything that has been answered, we will colour in green, just to help us keep a track. Obviously, as the session goes through, some of the questions that are asked may actually show up as having been answered already, and that's just by pure virtue of the fact that Gerard is good at anticipating these sorts of things and multitasking. Now, you are by design absolutely muted, and we obviously can't see you. You can see us, but we do feel your presence, and we'd love to hear from you in the chat room. So thanks very much for participating. Obviously, the more questions that we've got, the more interesting and interactive it is for you guys, so please do that. Gerard will try to engage you as much as possible in this one-way kind of format. We are recording the webinar for those that couldn't make it tonight. There's been a huge amount of interest, so hopefully those that couldn't will get the recording afterwards. Now, just as a matter of interest, down the bottom right of your screen, you will notice that there is a little file. It's not exactly where it is, but bottom right, you'll see a little file. If you click on that file, there's a whole heap of links and also a document that you can actually download and will pop up in your browser. Those links relate to things that are located in this particular webinar, and obviously the download you can download and save, but we will get that out to you, as well as the PowerPoint, all of the links, etc., as well as the recording, certainly not directly after this session, but within the next 5 days, or at least after Easter. Give us a couple of days. Rightio. Now, of course, we couldn't put these webinars on without the very grateful support of our sponsors, and tonight's webinar has been supported and sponsored by WAGPED, so we thank them very much for their contribution to allow us to bring this to you, and obviously very much to Gerard for coming and joining us and being with us tonight. So without any further ado, I'm not going to stand on ceremony and tell you any more that you don't need to do, other than that for those of you who don't know me, my name is Glenn Wallace. I'm the CEO of GPSA, and you are very welcome. Great to see you. And Gerard, please let them know, well, for those of them that don't know you, you could perhaps start by telling a little bit about yourself.
Great, thanks very much, Clint. It's a great pleasure to be here and be invited to do the GPSA webinar presentation. I suppose I'm thinking you can see me, but I can't see you. Most of my time as a supervisor, if I was watching something like this, I'd be sitting back with a glass of red wine somewhere and probably flicking on and off. So hopefully we can keep your attention in the evening after presumably for most of you a clinical day. So a bit about me. You know, people normally when they talk about themselves usually start with their clinical stuff and then move to their personal stuff. I thought I'd do it the other way around and talk a bit about myself. I see Ahmed's on, who recently had a show, which I was interested. I personally, probably my little bit of claim to fame in the GP world is my fact that I co-wrote with the wonderful Genevieve Yates, GP the Musical, which was put on at the Melbourne Comedy Festival a few years ago. So I have to confess, and that I'm basically a musician who's a GP. So I try to think of myself as that. And a lot of my becoming medicine and music coming together came through this band, which is Australia's only all GP. Sorry, it's a 12 GP cover band, Australia's only cover band featuring completely GPs. So called Simon and the G-Pets, and that's one of our earlier sessions in when we ran some gigs in Tasmania. You see there on our T-shirts. So I'm presuming there's no G-Pets on the conference. In fact, probably none of them would talk to me because I'm the bass player in that band, and no one ever talks to the bass player. So that's me as in my personal life. But I suppose here to talk about my life as a supervisor, and probably down the bottom here you can see this is my registrars and supervisors and students from last year. I had one medical student and 6 registrars last year, so I am quite experienced as a supervisor. I've been supervising for about 25 years. And my practice, up here is this little town of Dalesford, which some of you may know. It's a beautiful town, about 100 kilometres northwest of Melbourne. Here's my big surgery. We've moved into a combined surgery, and I'm a big greenie because we've got 30 kilowatts worth of solar panels on the top of a surgery. Here it is over here as well. So that's so I work in quite a large practice, and as I said, with lots of registrars and supervisors. We have about 15 GPs in our practice, including those registrars. But in terms of my role as a medical educator, in addition to being a supervisor, I'm a medical educator. I've just put at the top there some of my interests as a medical educator. I've become very interested in what supervisors need to know to be a supervisor. So quite a few years ago, I sat down with a group of experts and we tried to nut that out, and we wrote for the first time a GP supervisor curriculum framework. There are links to all of these points, all these files in the folder to the bottom right. So I'm involved in writing the GP supervisor curriculum, which also links in with my more recent work with a group called the Gully Group, which is doing the same sort of thing, trying to say if we were to do a course for supervisors, what would that look like? What would the modules be? And we'd love to work that up, and we had an article published on that in the AFP recently, but obviously the changes in the RTPs, RTOs, that's sort of taken a little bit of a hiatus. Previously, other work that I've been involved in, I've been very interested in how the supervisor works during the day. This is what I wrote in an article in AFP. I called it Consultation Interruptus, and Tim Clement, who I see is online, he beautifully coined the more correct phrase with ad hoc supervision, that supervision which you're doing on the fly. I'm obviously interested in random case analysis, which I'm talking about today, and I've got an article, hopefully will come out soon in AFP, on blended supervision, which is a combination of remote and local supervision, particularly looking at using that in Aboriginal medical health services. My research, I've been involved in research on supervisor motivations and teaching methods. I've had a couple of papers published of that, one in AFP and one in BMC Medical Education. I've had a couple of papers published on random case analysis, particularly one on random case analysis and supervision that I'll talk about today. And more recently, I'm working on changing the ECTV, so you have random case analysis as well as direct observation in the ECTV. So they're my interests. But tonight, we're here to talk about supervision. Here's, for those of you who haven't seen it, here's the definition which has probably traditionally been we use. The wonderful Susan Wern has recently done a literature review and proposed a new definition for what it means to be a GP supervisor. But when I first started working on this was the definition we went by, and it's, as you can see there, it says a supervisor is someone who provides guidance and feedback on matters of personal, professional and educational development in the context of a trainee's experience of providing safe and effective care. And there are really two parts to that when you look at that definition. That's the professional and educational development and safe and effective care. And one way of looking at is to in fact divide supervision up into two sections, into clinical supervision and educational supervision. When I'm thinking about clinical supervision, what I'm thinking about is the patient safe? You know, because you're responsible for the patient's safety. Whereas educational supervision, I'm thinking about is the learner learning. Now, a lot of time, of course, most of the time when you're supervising, you're doing both. You're teaching and supervising. But there are some times when you're straight out just educating. For example, if you're sitting down with your registrar to develop their learning plan for the term, well, that's clearly educational supervision. Whereas clinical supervision, that will be more like the ad hoc supervision during the day. There's some learning that's going on that, but when you're called into another room to see about a patient, your prime focus is really on making sure that the patient is safe. So this is sometimes quite a confronting phrase for supervisors to think about, that you have clinical oversight and management of the registrar's patients. You're responsible for their quality of care and the safety of their patients. And it raises this great question, which was written in an article quite a few years ago by Patrick Byrne. That whole deep question is, are they safe in there, and how can I be sure? And so that's what we're talking about tonight, clinical supervision. So at the end of this webinar, I'm hoping that you'll be able to outline and compare the methods used by supervisors to ensure the registrar is safe, and use random case analysis in clinical supervision. They're my two learning objectives.
Gerard, sorry to interrupt. How do you think
I might have been talking a bit too fast, but outside of that, it seems to be going all right.
Yeah, I'm not sure people are engaged. I'm not seeing much.
I hadn't picked up that they weren't engaged. Maybe it's because I hadn't really picked that up. Sometimes we just don't know what we don't know. And realise that we're all, underneath it all, unconsciously incompetent. Okay.
You might be on something there, mate.
So, and in fact,
righty, I'll let you get on with it.
So effective clinical supervision will uncover the registrar failing to seek help when they know they should, so-called conscious incompetence, but also to pick up the registrar who doesn't know, their unconscious incompetence. And I suppose this was most famously described by Donald Rumsfeld.
There are reports that there is no evidence of a direct link between Baghdad and some of these terrorist organizations.
There are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we do not know. But there are also unknown unknowns. The ones we don't know, we don't know.
Excuse me, but is this an unknown unknown?
I'm not.
Several unknowns, and I'm just wondering if this is an unknown.
I'm not going to say which it is.
But the Secretary,
I'm right here. I'm right here.
So for all the what was made of Donald Rumsfeld and the rubbishing he received for that, he was in fact correct. I suppose the question about going into Iraq was whether, you know, was it a known unknown, in which case they went in anyway. Yeah. And as someone has said there, I agree, presumably if you do drink too much red wine, you will go from unconscious incompetence just to straight unconscious. So, we all should have one of these T-shirts. As you can see, mine's looking a bit tatty. I wear mine to bed, where I'm probably also unconsciously incompetent. So I've got a question, which is a question that I asked a whole lot of supervisors quite some about 2 years ago, and we're gonna poll this and see if we can get you involved by polling you. When you last had your last registrar, how confident were you that you could assess their competence? I'm not asking you whether they're competent or not, but whether you were confident that you could assess their competence. So I think you can just tick a button, and the answers are coming up there. Oh, you're all very good at the clicking, aren't you? You're all competent clickers anyway. So we can see there the numbers are coming up. You're all bashful like you lot online. Obviously, it's quite a different result than what we received when we asked people anonymously on a paper survey. They were not as confident they were much more confident than you lot. Okay. We'll close that, Glenn? I close it? Good. In fact, when I asked, we surveyed 93, or we've got 93 supervisors attending an annual education workshop beyond medical education, my previous RTP. We actually had 93% of supervisors rated their ability to assess registrar competence as either confident or highly confident. Okay, between the 3 and 5 on that scale, whereas you were a bit lower than that. And we were a bit surprised at that because they scored that highly despite the fact that very few of them, well, they infrequently used observation or audit activities. That was, so what was the basis for them being as confident as they were? The other interesting thing we found is the longer a person was a supervisor, the less confident they were about their ability to assess registrar's patient safety. It was a negative association. So someone like myself who's been a supervisor for 25 years, as time goes on, we actually get less confident that we can assess our registrars. And reflecting on when I saw that result came out, I reflected on it probably at the start. I thought, oh yeah, this is all pretty easy. But as time went by, I became more aware when you do have a registrar who's not as competent, it's actually quite hard to detect that, and it can take a while to do it. So, of course, if you only have very competent registrars, you can be lulled into that false sense of security that you really know what's going on in the room next door. So that's my first slide to suggest that maybe sometimes we're a bit too confident. And the next one, I went to a presentation last year with Graham Lee from GP Synergy at the GPTE conference, and they did some work with the PGPP registrars, and in their research, in PGPPs in New South Wales, you had to observe someone and see that they were competent before you allowed them to move to the next level. You've got these levels. The basic level, this would be like, medical student first year, does not see patients alone. This is the next one where you're allowed to see a patient on your own, but then you call someone in immediately after the consult. This would be the one where you can see patients and you call for help when you need it. And this one is more, you're just getting an overall broader mentoring type process. And so when they actually observed people and didn't allow them to move to the next level until they were happy, GP Synergy found that only 50%, or 50% of the supervisors of the PGPP doctors remained in these bottom 2 levels and didn't progress up. And so that means presumably that about 50% of registrars are coming into general practice really at that level. Yet it's probably true that most of us start our registrars in practice at this level. That gets reflective that the registrar starts consulting and they call us in for help when they think that they need it. And speaking around the country, that's my impression. Most supervisors start at that level. I've spoken to a few, probably the legendary Peter Stevens from Hayfield. He runs a practice where he teaches all of his learners the same. He has the sort of the classic vertical integration and wave model consulting, and he observes everyone before he allows them to move on to the next level. So he does the same process. Thanks, Tim. You're actually putting up some links to some of the things. So that sort of suggests that's what is done down at Peter does down in Hayfield. Peter Stevens. The other, I was struck also once when giving this talk that a supervisor told me that she went home and looked at the registrar's every record for the day until she checked every day, every night she went home. She said it didn't take her long, and after she'd done that, she felt much more settled about knowing that a registrar was safe to practice. So although she didn't observe everyone, she actually checked the records on everyone. So maybe that's, and generally when I've said that, most supervisors said, well, I can't do that, but it's something to think about. So why is it that we have this training environment where we have it's set up where we probably have people coming in at a level and being supervised at a level probably higher than they should be? And look, I'd say there's probably 2 reasons. The first reason is historical. Of course, I'm old enough from FMP training. When I came into training, it wasn't a compulsory thing. I finished my medical degree. It was presumed that I was ready to be a GP. There wasn't, GP training was not compulsory. So it was historically seen that anyone entering into general practice with a medical degree was ready to go and start seeing patients without being. So our training environment has been set up on that historical precedent. And the other reason, I suppose, is time and money, is because unlike in hospitals where registrars are they're not on a fee-for-service model, whereas for most of us, we're trying to not only not only teach, but we also have to, if the registrars aren't seeing patients and seeing patients independently, they're not making money. So there's strong incentives for them to be working at that level 3, level 4 as soon as possible, which almost works against safety, is my point. So perhaps, how do you know that your registrar is practicing safely, and how will you keep an eye on your registrar? And perhaps if some of you want to try and type in some answers about how you keep an eye on your registrar, how do you know that they're practicing safely? What clinical supervision techniques do you use? Or how do you know that your registrar is safe, that their patients are safe? Okay, great. Some answers. Ask somebody to talk to me about the patients. So someone, Leslie says about each patient. So that's sort of at level 2. Whoa. Need to, great direct observation, check notes and pathology. How do I know if I'm practicing safely? That's true. Do a list review, morning ward rounds is true. Try and do observe consultations, file audits, random case. Great. All right, so all of you are actually doing quite a lot of no unusual deaths, is true. Hopefully you pick it up before then. Case no unusual deaths is true. Hopefully you pick it up before then. Case discussions. Okay. And like that sort of, you all look to be, I suppose, probably we've got a selection of supervisors, those who are willing to come on to a webinar at night, are those who are reasonably conscientious and trying to do a lot of these things as best they can. Okay, great, good. We're seeing lots of ideas that we're doing. Generally, we get these sorts of answers. You're actually giving, again, you're a different bunch than what I would normally get. Normally what I get a lot of the time is, oh, look, I get feedback from the staff. They tell me when the registrar's not running so well, or yeah, getting the post in GPDU, definitely, Tim. Well, they'd be following you a lot. And sitting in observation, that's obviously another method. Review of video recorded consultations. Some people say, I get to know when next time the patient comes in, I get to fortuitously see the notes. Some say I do an audit of records, an audit of investigation records, or just I get a feeling of how much the registrar knows during the teaching encounters. Okay. So, can we put a poll on this? Glenn, great. So perhaps we'll let you apparently you can put multiple answers, but if you want to just tick 2 that you think, so which of these do you think are the most reliable in uncovering, the registrar with these, the unconsciously incompetent registrar? So just put in 2 answers, your top 2. All right. So we're seeing there the top 2 rating there are not feedback from staff about the registrar, which I mean, I think when you get that feedback, it's actually very useful. But you're getting strong results there for sitting in observation of registrar consultations and audit of patient records. To be honest, it's a little bit of a trick question because it would depend on what you're wanting to know. If you're wanting to know about your registrar's communication skills and ability to read a patient and how things are going, then the best way would in fact be sitting in and observing registrar's consultations. Whereas I think if you're actually wanting to know about their clinical knowledge, it's probably better on a patient records. So if I go forward, I'd say that's my top 3 would be an audit of patient records, an audit of test ordering, and a direct observation of consultations. I base that answer because an audit of patient records if I want to know about clinical knowledge, I'm going to be able to go through lots of patient records quite quickly. You know, if I'm sitting in and a patient they're seeing registrar seeing one ERTI after another ERTI after another ERTI, I mean, I might get a good view of their consultation skills, but I get very little understanding of their knowledge. And you know, you can't rush the patient out the door, say, look, I've seen this already, you know, I don't need to assess him anymore on this ERTI. I'm ready for something else. Whereas you can quite quickly say, look, let's not look at that. Let's not look at that note. Let's move on to another one. The same sort of thing, I'd say the next is audit of test ordering, because you can ask, well, why did you order that test? There's an advantage in an audit of test ordering, because if you think about it, registrars will often order tests when they're uncertain about something. So it gives you a bit of a window into the sorts of things that they're uncertain about as well. So that's a reason why, although I don't think it's as good as an audit of patient records, I think it gives you another in. And then of course I think direct observation of consultations would be my number 3. And I put that above video observation, because direct observation, they don't get to choose video observation, they can choose which video they get to show to you. Okay. So what is the evidence? You know, fair enough, I have that opinion. What's my research evidence for random case analysis in clinical supervision? We did pre and post random case analysis workshop survey results. Again, it was about 90 supervisors. 80, it was a very acceptable method. What I'm telling you about tonight is a very acceptable method. And we found, when we asked supervisors that question we asked you before about how confident are you about your ability to assess the registrar, we had a statistically significant increase in supervisor confidence once they were using random case analysis. Most importantly, 30% had identified a patient safety issue using random case. I mean, imagine that. By actually opening up the records, you done 30% there was a patient safety issue, and 16% had actually had to contact a patient about management after using random case analysis. So with evidence like that it's an acceptable method, that it is a statistically significant improvement in your confidence after using it, you'll uncover those patient safety issues and whatever. I can't see, this argument would really be, why are you not doing this? So let's just talk a little bit about random case analysis. And there's some nice big thumbs up coming there, thank you. So first of all, are you using random case analysis or some other form of medical chart review other than opportunistic review currently? Can we poll that one, Glenn? Waiting for a yes, no. Maybe I'll just move on, Glenn, sorry. So when I've asked around, oh, here we go. We'll choose yes and no, see what happens we get there. How many are doing it currently? Okay. This is going almost exactly what if the poll hadn't come up, I would say that when we ask around, we get the reverse of this. Again, I think this is a select group. We get that about 1/3 are using it and 2/3 are not. Okay, whereas it's a reverse option for this, but I think that's really a reflection of this group that's here. So look, I'd have to say that I'm not really telling you something groundbreakingly new, something that's not bleedingly obvious, that it's worthwhile doing it. I'm not really going to be telling you something for the 2/3 of you, that not something more. I might have a slightly different take on it, and you might be interested to see the evidence, but it's just such a common and important tool for GP supervisors. Interestingly, it's part of the training program overseas, but not part of the training program. Well, under the previous regional training providers, there was random case analysis was not part of the compulsory formative assessment program of any RTP under the previous iteration, whereas it is in the UK. So what is it? It's a review of a random sample of medical records with the registrar to assess their clinical knowledge, decision making, and the quality of the medical records. Okay. Reverberation, bass player. Oh wow, I'm always very clean. So random case analysis. It's a medical audit technique with a little extra. It's random. I know that many people say, well, it's not, what I'm describing is not truly random. We don't do a random selection. We generally just select, well, open up your notes from yesterday morning and we go through them one after another, but random in a non-researcher sense. Case, we chose that to say that because we don't just look at the record, but we actually discuss it with the registrar and explore it. And that's the other part, the analysis. We explore the case to understand the registrar's decisions. So that's the reason we use that term. You'll see other terms used Internationally, different terms used as well, such as random record review, random case audit, chart audit. Some of them are just a straight audit of chart, whereas I think there's a greater richness when you actually sit down with the registrar and discuss it with them. So the method which I'm going to describe to you now was in one of those links that's published by Simon Morgan and myself. We developed around an approach, and look, if Acronym, I'm sorry that it's an RACGP domains, it would work just as well with Acronym domains, I'm sure. The idea we had was that it's probably to use the RACGP domains to help you explore the consultation more. Random case analysis probably leads itself best to domain 2, applied professional knowledge and skills, and domain 5. So domain 2, looking at what they've done and why they've done it, and domain 5, looking at their quality of their notes and their certificates and that sort of thing. That's where its real strengths are there. But it's not to say it can't be used for the other domains, and that's probably what I'll talk you through. You can ask under domain 1. You can ask, well, what was the patient's agenda? Did you hand out information at the end? What was going on? Under domain 3, you can ask questions about their population health, and clearly professional and ethical issues come up anytime you open up notes. In addition to exploring the domain, the domains, we also think there's an opportunity to explore it further by asking what-if questions. So any situation you can ask, what if the person was different? What if the system was different? What happens if you did have access to an X-ray immediately? What happens if the doctor was different? What happens if you hadn't had that experience of sending a patient home with a sore throat, only having them coming back with rip-roaring tonsillitis later, or or the problem was different? What happens if it was really glandular fever, not tonsillitis? And you can explore what if, taking the basic scenario which you've got in the notes to explore it further. So we use that together. And the process we do is basically you start, I mentioned, you sit down with your registrar, you'll say, let's open up your appointment book from yesterday, let's pick the first note. So you open up the first note, first thing you do is you clarify, what did you know about this patient before? Had you seen them before? How was the day going for you? Was there anything else other than what's in the notes here that you can remember when you're looking at it now? So you get some clarify. Then you explore using the star, the RACGP domains, and then you use the quadrant, the what-if questions. Okay. It is exactly all primary care, whether it's Acronym or RACGP. One thing when we've had supervisors had some, I get very excited when I see someone with a nerdy. It always makes my day too. One of the things when we have people, when we do training for supervisors and we get them to go and practice, sometimes we hear them, it feels like they're interrogating their registrars. Where were you on the night of the 27th, that sort of thing. Be careful that you don't turn it into an interrogation. So although we've listed all those questions, I would generally not think that you would ask all those questions or ask a question from every domain. It's just there as a guide to enable you to think of some questions and to encourage you to explore outside of domains 2s and 3s. In terms of the red question, does random case analysis work with small groups of 2 to 3 GPRs each doing a case, or better one-on-one? Look, I've actually never done it other than one-on-one. I suppose there's an element of, I think it really is suited to the one-on-one for the registrar to explore their own understanding. But I could see that it could certainly be done with 3. I suppose there's a little bit of a danger in that, in terms of you suddenly, it's not necessarily such a safe environment. The registrar doesn't know which record you're going to pull out next, and if they're a bit exposed to their colleagues, it's probably something, just thinking about it off the top of my head, it's probably not something that I'd do with 2 to 3 GPRs. I'd probably do it one-to-one. So just replacing that again, just putting that all together, there's the star and the of general practice and the what-if questions again. Okay, so let's have a go, seeing how we go. We'll have an example. Imagine now you're sitting down and you're with your registrar and you say, let's open up the first records, and here's the record that's opened up. I'll let you read through that. Yeah, group random case analysis. Okay. Not a completely atypical example. So, to go through the process you would do, you would clarify. As I mentioned, you do, what did you know of this patient before? Was this patient an extra in emergency? Was his wife in the room? There are no notes to say you did. Did you examine the liver? You might want to look at the ECG so you can make sense of it. Okay. Can you come up with some questions which you might use to explore domain 1, communication skills and the doctor-patient relationship, about that record, about this one? Okay. What questions might you do? About his communication skills and doctor-patient relationships. What was the concern? Ask me what was the concern of the patient is relative. Stop Voltaren. What do you mean by that? Well, you might be telling him to stop Voltaren, but that's not to do with communication skills. What are the patient's ideas of concern? Was he worried about his heart? What did the patient think that it was? Exactly, all those sorts of things. Do you think your patient was happy with the consult? Yeah, beautiful. So they're exactly the sorts of questions which you'd ask in domain. You're such a good group, aren't we? So yeah, what was the patient's gender? These are, what do you think the patient expected the outcome to be? Was the patient happy with your plan? Okay, let's just look with this same one. We're exploring domain 2. As I mentioned, a random case, there's a million questions you could ask here. Probably the question is to limit them. So again, what is applied professional knowledge and skills? Again, looking at, sorry, get that history up again. Whoops. There he goes again. Yeah. What differentials did you consider? Okay. Questions about tests. So they're great questions to ask about. Yep. Any other questions? Tell me about the ECG. Yep. What's his interpretation of it? He's definitely going to see their knowledge of ECG reading. Yeah. Great question. Are you comfortable excluding it on the grounds of a normal resting ECG? What's not to miss? Did you perform a systems review? What follow-up arrangements did you have? Yeah. Plan for patient getting worse. Yeah. Yeah, why Nexium 40? There's a million questions. Sorry, someone's not getting the, can see the picture, only audio. Ah, well, sorry about that. Hopefully you'll have to watch it later. Yeah. Did you consider any tests? Yeah, great. First attack and recurrent attack. So there are lots of good domain 2 questions which you're asking there. Sorry, it might just be quick for me to go through. So these are the questions that I'd had there. What other diagnoses do you consider? Similar questions. You have recorded review if it gets worse. Is that what you told the patient, or were you more specific in your safety netting? Yeah. So great questions about what's the likelihood of the ECG we've asked of that really being a sensitive or a specific test in this circumstance. Yeah. Yeah. Did your examination cover all likely diagnosis? These sorts of things. Great. There's endless questions we could ask and explore domain 2. So you can see it'd be very easy to get a strong knowledge not only of the decision that he made there, but also of, you could explore into other knowledge, his ability to read ECGs, his understanding of ischemic heart disease. Great. Yep. Good. CV risk calculation. Yeah. So you can see at the end of that, you've got your teaching session. You start the first. The big trouble with random case analysis, you open up the first record, you've usually got enough to talk about for your whole teaching session. So any population 3, now we're getting, that was the easy domain. Here's the tougher domain. Population health in the context of general practice. Can people come up with anything which they might ask for William Smith when it comes to population health? Yeah. We've got his age of his patient there. He's 50. Oof. 59, 58, 59, 58. Yeah, what is likely diagnosis of people of this age? Yeah, smoking status, population health, I suppose that's true. Weight and height. Oh, you're all doing well in these things. Alcohol intake, other lifestyle factors, yes. Fly in, fly out, interesting. Occupation, great. Screening bowel cancer, racial. You're way better than me. Couldn't get any of these ones. Oh, good, great. You're thinking more broadly on the public health theme than I am. Yeah, the impact of the patient's gender on presentation management, RACGP Red Book guidelines, but you're thinking, yeah, much more broadly in terms of the context of where he's living and his environment and his general overall health, his screening health and general health. Fantastic social stresses as well. Wonderful, yeah, really good stuff. So again, where I thought that domain 3 was thin, you're quite happy there in domain 3. Professional and ethical role for this one. I could only come up with one question that came to my mind with this. Any professional and ethical issues that come to your mind when you see this? What's your duty of care here? Yeah, good question. Yes, legal context. I suppose organisational legal is the 5th domain, but yeah, what would the coroner say? Yes, oof. Privacy. Yep. Sick notes probably go organisational legal, but yeah. Safety netting, I suppose, really is in some ways it is a professional and ethical behaviour thing. Does he drive? Again, some people would see that in population health, but it's true. What we're seeing here is, I might say that belongs in this or that domain, but what we're seeing here is by using the domains, it's generating lots and lots of questions. Okay, generating lots and lots of questions for you to ask. Yeah, yeah. Why did he see the registrar, not his usual doctor? Nice questions. Okay. Okay. So, ooh, I'd gone beyond there. Domain 4. Sorry. So I had a simple one for me was, did he actually consider calling for a second opinion? Did he actually consider that it was a second? You might want to get a second opinion. You know, what were the reasons why he, or presuming it's a he or a she, didn't seek a second opinion? Thank you. Okay. So that's under domain 4, professional and ethical. Some of these have been covered there already. Sick notes and medico-legal issues in terms of if you miss a diagnosis, what's the issue? How would that be handled? What would the coroner think? As you say, driving. Any other issues? You did not need a second opinion. I suppose what I was getting at there was that if I found during the conversation that he actually did have some uncertainty about his diagnosis, and he may not have, if he didn't have uncertainty if he did have uncertainty but didn't seek help, that would raise concerns for me about professional and ethical behaviour. Okay? Yeah, what if you had more time? Great. Yeah, exploration of how long the consultation took, those sorts of things. PBS indications for the prescriptions that are provided. Yep. Yep, great. Quality of the notes, can they stand up to scrutiny? Exactly. The 2 standards, of course, is it should be enough to enable another doctor to take over the care, to understand what's going on, and to enable to justify any billing which is done. Okay. Medical certificates. That's a great thing to discuss with registrars, isn't it, when you actually open up the notes and see how long they provided certificates for, or didn't, as the case may be. Okay. Okay. Yeah. Records a bit light on, history detail taken. Yeah. Lots of things. Okay. I've got even simple things like, do the typos in your notes matter? Are your notes clear? What item numbers did you bill? And do your notes justify the billing? These sorts of questions. So I think, again, what I've seen is that a group of supervisors is much more powerful than one. You've got to come up with wonderful questions by going through the domains. Then after you go through the domains, we'll the what-if squares. So they consider the differences in the problem, the patient, the doctor, and the system, rather than asking you to go through all of those. So I've got these ones here, just some examples. The problem was different if the pain didn't occur after meals. What if the person had a past history? This was a different patient. What if you hadn't been running so far behind that day? So was that impact upon you as a doctor? Or the system, what happens if you had access to point of care troponin testing? Would you have used it? Would that have made a difference? So you can propose, you can take that same scenario, and particularly for those of us, or for those of us who aren't working in an urban situation, so those who work in a rural situation, you say, how would this be different in urban versus rural? It could be, and regional versus rural. I mean, these sorts of really a great way. I mean, I'm not in by far a remote, but I'm in a rural town rather than regional, and it's quite interesting to explore how things will be done differently regionally versus urban and rural. Okay, so the what-if questions are wonderful in terms of helping people to understand the system that they're in. So I quite like the what-if questions. The what-if questions really are very much going more into educational supervision, much more learning than clinical supervision, but still very useful. Okay, so if you want to know more about the use of random with this model, which I've just taken you through, which is a model which is based upon, as I said, the just basically opening up the records, clarifying what's going on, and then exploring using the STAR and the what-if questions. You can read the article which we published in AFP, and which is also in the link in the folders and will be sent to you, I think. Running just a slight bit ahead of time, which a bass player was always happy when they're slightly ahead of the time. I just wanted to, Glenn, I just want to check whether I want to check these are the learning objectives which I set for the start. Exactly. I think that in a remote Indigenous setting, it's probably fascinating to ask questions to do with that as well, and how is it different in that context would be very important. So I just wanted to check, these were the two learning objectives which we set. I just want to see whether we've managed to achieve those, whether we can do that by poll. Glenn, did you manage to set that up? Are you on, Glenn? I'm just going to answer some of those questions. Oh, okay.
Sorry, no, I haven't got that one in, but I can do that if you keep going with the next slide. I will.
Okay. Well, I want to. That's all right. We will. I gather you send out evaluation anyway. Is that right? You'll ask these two questions. So we could have actually seen that online and seen, in terms of as an ability to actually get evaluation, which I suppose as a teacher, I'm trying to actually role model the fact that at the end of a teaching session, it's probably not a bad idea to find out how that teaching session went and to get some immediate feedback. Yeah, secretaries all now. How many? Can I answer some of these questions now, because we have got time to answer questions? How many cases do you try and cover in one teaching session? Do you know that depends on the circumstance? If I'm using it really as a learning exercise, I don't get too fussed about how many cases I cover. If there's lots of learning to come out of one case, this one case, we could talk about that the whole time. But when I'm really wanting to assess competence, or perhaps if I was really wanting to be knowing that they were safe, yes, it's quite true. I want to get through as many cases as I want to get through as many cases as I want. Okay. All right. So, Conrad, what are you doing? Okay. Oh, look, Conrad's raised a very important point, which is when we've done research on this, there's no point asking them about consults from 2 weeks ago. If your registrar comes back on their first day back from holiday after 2 weeks, don't do random case analysis about the ones they've done 2 weeks ago. It's really very little, because you want to be able to ask them, what were you thinking during that consult at that time? Okay. True. Great idea. Conrad, you're firing gold there, mate. You can do reverse random case analysis. Look at your own. That's a bit freaky. Ahmed, how did I hope your comedy session went very well for you. No, I won't encourage Conrad anymore. Yes, we can all learn from our students and registrars. Okay.
Jared, we might take a pause there and ask everybody to complete
You're
that
champion
poll, if you
secretary,
like.
Glenn.
Is that a
Oh, they're going to
chance?
ask about both. Yes. Oh, there's only two options. Yes, I know.
Okay.
Perfect. 100%. Yeah, you got to get one though. Because it was interesting setting up the learning objectives for this session. I mean, use random case in clinical supervision. I mean, that to set up a learning objective that's a bit higher than that. You know, because we actually haven't had an opportunity for you to practice it other than going through those questions and seeing the answers. But look, to be honest, I think that this is the feedback so acceptable to supervisors, and as you can hear from the positive response of those people who are doing it, that people don't seem to need a lot of training to be able to get up and using it. It's not that hard to open up the notes and start asking questions and seeing how they go. So great, that's really good to see the positive feedback that I haven't achieved my learning objectives for only 4 of you, and maybe there were grades of grey there rather than full yes and no. Okay. So that was my question. So in terms of where to next for this, if you haven't, though 60% of you already have a go at using random case analysis in your teaching sessions, but also taking a more broader view, and particularly for those of you who, like me, work in a larger practice, how will you assure your registrar is safe in there? Because it's even more complex in a larger practice because you've got to be, how are you as a group of supervisors making sure your registrar is safe in there? Recently we had a registrar who ended up needing focused learning intervention, and we realized that it was because as a group we were doing, the registrar was getting a little bit of teaching from all of us, and it took quite a while for us to realize the registrar was in need of further assistance because of the way we'd set up our supervision. We thought it was fantastic spreading the load, but there was a downside to that about communication and picking that up. So I think that that's really, for those of you in larger practices, think about that, about how you know. Okay. And myself, I'm actually trying to do some further research into random case analysis, particularly its use when combined with consultation observation as a multimodal assessment. So we were going to do ECTVs where, and look, some of you do ECTVs at the moment. If you go out there and the registrar's only got a couple of patients and there's no one else booked in, open up the notes and do random case analysis. The research which we've done, which there's a link there, publishers found that's a very powerful and because it gives you a different insight into the registrar, because you can see what their practice is over time, and you can actually see what they're actually recording in the notes. And obviously, when you go in and observe them, they do this fantastic show while you're watching them. But random case analysis is an assessment of what they really did a day or two ago. Obviously, it can be embellished with what they say, but it is actually a true measure of performance, which is what we're wanting to do. Yeah. Ooh, looks like you're getting some more GPSA questions there.
That was a question about whether we could make
to.
this available on FOMED. Yeah, absolutely, no problem at all. All of the content that's generated through the webinars is obviously available to members, no problem at all, and everything's recorded. So
okay,
certainly
thank you for all listening, and wonderful. Supervisors are my inspiration. You're all doing this fantastic work out there. You're doing the work for our future GP workforce, and I think it takes a lot of altruism to be a supervisor.
Absolutely, couldn't agree more there. Thank you very, very much, Jared, for giving up your time.
And finished on time, Glenn.
You've done a beautiful job at bringing this in within the
Sorry if it's been rushed.
hour. I know. Well done.
You're giving the right amount of money there, Tim.
And for those four that still are none the wiser, Jared will.
It's an anonymous poll.
Phone you and,
happy to take any questions. And I think I did have my email address on there. Happy to receive any email or any questions about that. Dr. Gingham at supervision@gmail.com. Good.
Absolutely, absolutely. And thank you for being so accessible there, Gerard. Obviously, we love your feedback. We obviously change and amend and guide our speakers through the feedback that we receive at the end of each of the webinars. We've actually scheduled the survey for this webinar to go out before the end of this session, so that should be in your inboxes right now. And you may be interested in our next webinar, which will be on identifying and supporting registrars at risk, and that will be put together and presented by our very own
Beauty, I'll get onto that one.
who's also in the audience. So that will be fantastic to hear from him. Absolutely, don't miss it. And we look forward to seeing you all again. It's been fantastic to have such a great turnout tonight and see the support for GPSA peer-to-peer learning and some really fantastic presenters, both past, present and future. And if you're unconsciously incompetent, keep coming. Thanks very much.
Thank you.
And,
good night all. Thanks again.
Gerard, have a good night. Cheers.